Hello and welcome to the final session. It's an exciting agenda we have for you, going and climaxing into a very interesting discussion at the end. So without further ado, I welcome my co-chairs and I put in some condolences for those of us who have family back in India who are going through a very difficult time. For some reason similar to that, one of our co-chairs is not able to attend. So we extend our heartfelt feelings. The first presenter, it is my great honor to introduce Alexander Smith, who is presenting on salvage pulmonary resection in stage 4 lung cancer after pembrolizumab, a case series and a literature review. Thank you.
Hello, my name is Alex Smith. I'm a cardiothoracic ST4 based at Guy's Hospital in London. I'm here today to talk to you about our experience of salvage lung resection in patients who initially present with stage 4 lung cancer following treatment with immunotherapy, specifically with pembrolizumab. So immune checkpoint inhibitors targeting the T-cell programmed death receptor 1, PD-1, have shown to have markedly improved survival in patients with both locally advanced and metastatic non-small cell lung cancer. However, the role of salvage thoracic surgery and lung resection in the management of residual disease in terms of both outcomes and cancer recurrence in patients treated with immunotherapy in stage 4 disease, or in patients who initially present with stage 4 disease as well as a synchronous early stage lung cancer, has yet to be defined. I'm presenting today a case of 5 patients successfully downstage with combination chemoimmunotherapy who proceeded to salvage pulmonary resection. So immune checkpoint inhibitors essentially work by allowing the innate immune system to identify cancer. Indeed, the failure of immunosurveillance mechanisms play a key role in development of cancer, and the ability of a malignant lesion to evade the innate immune system is a hallmark of malignancy. Programmed cell death protein 1, PD-1, acts as a checkpoint during the effector stage of the immune response on binding the ligand PDL1, signaling pathways within the T cell are upregulated, resulting in diminished proliferation, cytolytic function, and cytokine release. Immune checkpoint inhibitors targeting PD-1, such as pembrolizumab or PDL1, expose tumors to this our innate immunity and have been shown to significantly improve survival. There are a few studies and more than a few studies ongoing considering the impact of both neoadjuvant and adjuvant immunotherapy, but there are very few reported cases of salvage pulmonary resection following immunotherapy for persistent primary lung lesion. And a review of the literature, there are currently only 7 published case reports in series comprising 14 patients that have reported outcomes following surgery after definitive immunotherapy for stage 3 to 4 lung cancer. The main reported surgical challenge is related to hilar fibrosis, frequently necessitating an open approach. Only 1 series has been published of 100% successful minimal access surgery in 3 patients following downstaging. In all 3 cases, surgery successfully undertaken using a VATS approach. In our series, we had a total of 5 patients with a mean age of 59, 4 patients of female. They were split into 2 distinct groups, 3 patients in whom surgery is indicated for residual disease and following residual pulmonary disease following a marked response to metastatic and nodal disease with immunotherapy, and 2 patients who initially presented with stage 4 disease who were subsequently found to have synchronous lung primaries. Their stage 4 lung cancer showed marked and complete pathological response to immunotherapy, but with a synchronous contralateral lung lesion that grew whilst on immunotherapy. There were no in-hospital mortalities and no post-operative complications. Complete oncological resection was achieved in all patients who remain free of disease between 6 and 18 months follow-up. And this is a busy slide, but it essentially shows you the 3 patients in whom surgery was undertaken for residual pulmonary disease. You can see it, for example, patient 1 initially presenting with T3N2M1B cancer, and that was restaged radiologically as a T1B N0 M0, then underwent a right thoracotomy upper lobectomy, with a 3 millimeter deposit of active adenocarcinoma found on histology, currently free of disease at 12 months. And this image really shows the sort of impact that immunotherapy can have. On the picture on the left, you can see the primary lung cancer with hilar nodal disease, as well as a thymoma, and a metastatic skin lesion on the left flank. And on the disease, and on the picture on the right, just the thymoma is left, almost complete pathological response everywhere else. The second cohort of patients were both patients who initially presented with stage 4 disease with a contralateral lung lesion, a complete pathological response of the main cancer, as it were, the stage 4 cancer, where then with growth of the contralateral lung lesion, both subsequently resected and found to be synchronous lung primaries. Both patients are free of disease at 6 months. So in conclusion, salvage pulmonary resection may be indicated in select patients with advanced stage non-small cell lung cancer who have an excellent response to immunotherapy but persistent localized disease, or in those with a synchronous primary lung cancer that does not respond to immunotherapy. Surgery is safe and technically feasible. It can be considered instead of radiotherapy. Dense hilar fibrosis, as we found in all cases, may necessitate an open approach. Further prospective studies are, however, required to rationalize the indication of surgery, as well as review the long-term outcomes in terms of cancer recurrence. And thank you very much for listening. And if you have any questions, please do ask now. Thank you.
Thank you very much for that. That was a very exciting presentation, and in some ways preempts future of things to come. Why I would encourage people to rate the presentations, please, and also to type in questions on the type box and the Q&A box on the right. And at the moment, while there aren't any questions, may I just ask, what did you approach these cases as a planned thoracotomy, or did you assess them on VATS and find them unsuitable to proceed? And did the duration of time since the pembro treatment have an impact on how much fibrosis you saw?
So to answer the first question, we approached 4 of the cases open, primarily, which is the start of the learning curve. The final case, the 5th case we did, which is patient 2, the one with the thymoma, was obviously approached as a hemiclamshell, so we could reset the thymoma as well. Otherwise, that would have been approached VATS initially. But the 5th case we approached, we did the operation actually robotically, but because of lymph node involvement on the main PA, we then had to convert to a thoracotomy to allow an arterial sleeve at the time. And then your final question was about time. All of these patients have been on over 12 cycles of pembrolizumab, so actually the hilar fibrosis was quite intense, and we haven't got very much experience yet in this cohort of patients who have only received a few cycles, as it were.
Okay, so another curiosity, because the slides obviously go quickly. So I think I read about wedge resection. So
yes,
that's the treatment.
So
on why you would do a wedge resection for primary lung cancer?
So for the patients who had the synchronous tumours, they presented with a stage 4 lung cancer with metastases and a contralateral lung nodule. They then had a marked disease response, except for the contralateral lung nodule. Our approach was, because they had already been treated for stage 4 lung cancer and generally were quite cachectic and unwell, but they had this growing smaller nodule in the contralateral lung. We then resected that and then subsequently found them to be synchronous tumours. So that's why a non-anatomical resection was undertaken in them.
All right, all right. I mean, there's a lot of interest in minimally invasive approach after immunotherapy. And in an interesting way, I have developed quite a few experience. Which was no lung cancer patient. I have lots of patients with sarcoma, lung metastasis of sarcoma. They go through maybe in 20 or 2 years of sessions of immunotherapy. they are challenging from a minimal invasive point of view. But I do feel that, as Jay was sort of gently pointing at, starting minimal invasively, it should be a start point for most advanced thoracic centers.
I think since I've submitted this abstract, we've done 4 further cases of these patients and all been completed successfully via a robotic approach. So you're really just seeing the start of the learning curve that we've been through, really. But now our approach is very much always minimally invasive.
That's excellent. There's quite a few very interesting questions coming up. I'm sorry, in the interest of time, could I request Alex to attend to them in the chat box while I request Francesca to move on to the next speaker, please? Thank you.
Thank you very much.
I cannot, sorry. Helen.
Yeah, I'll do it.
Yeah, I can't find the program, sorry.
That's okay. So our next presentation is from Adnan Raza, and he's going to talk to us about pulmonary resection outcome for lung cancer in patients with borderline lung function.
Good afternoon, ladies and gentlemen. The objective of our study was to evaluate the outcomes of the patient with borderline lung function who underwent pulmonary resection for non-small cell lung cancer. As we are aware, in 2009, NICE guidelines recommended that we should offer people with predicted post-operative FE1 or TLCO below 30% the option of treatment with curative intent if they accept the risk involved. In methodology, this was a retrospective study with the patient with non-small cell lung cancer, and we recruited the patient between 2010 and 2020. Enrollment criteria included all comer lung cancer patients who qualify for the surgery with curative intent and they have FEV1 below 50% of predicted value. And primary outcome was post-operative all-cause mortality. We carried out various statistical tests to analyze the data, also including the Kaplan-Meier test and the Cox regression model. And all these analyses were carried out using the R statistical software program. Our results showed that out of 109 patients who were recruited underwent isolated first-time surgery for non-small cell lung cancer. The mean age the mean age was 69 years, and 70% of them were male. Mean FE1 was found to be 41% and mean DLCO 36%. Average post-operative hospital stay was 11 days. Out of these 109 patients, 58 patients underwent lobectomy, whereas remaining 51 underwent sublobar resection. 47% procedures were performed with the VATS. Post-operative TNM staging showed 68 patients having TNM stage 1 disease, whereas 26 patients have stage 2 disease, and only 15 patients in were in stage 3 disease of the lung cancer. On further analysis, it was shown that in patients with stage 1 lung cancer receiving lobectomy experienced worse survival than those with a sublobar resection. At 1 year, 3 year, and 5 year survival, it was 82 versus 87%, and 42 versus 76%, and 34 versus 59% respectively. After computation of the Cox model of proportional hazard, only age and lobectomy had significant influence on survival following the treatment of the lung cancer. Neither staging nor the tumor showed any influence on the survival. It was also shown that the patients submitted to lobectomy had higher probability of all-cause mortality with a hazard ratio of 1.72 than those treated with the sublobar resection. This chart showing the characteristics of the patient, 33 patients per female out of 109, and 40% patient were suffering from hypertension, 67% patient was having COPD, and almost 100% patients were having history of smoking, either they were current smoker or ex-smoker. other factors including age, mean age was 69, mean BMI of 26, and preoperative hemoglobin of 138. Post-operative complication comparing the lobectomy versus sublobar resection showed that more patients in the lobectomy group required the post-operative mechanical ventilation, which was statistically significant. Also, in the same group, more patients suffered from atrial fibrillation as compared to sublobar resection, again statistically significant, and there was a prolonged hospital stay in the lobectomy group. This slide showing the survival comparison between the lobectomy and the sublobar group of patients in stage 1 disease, and it's clearly showing the difference that the lobectomy has the worst outcome is the year 1, 3, and 5 as compared to the sublobar resection. In conclusion, sublobar resection for lung cancer patients with borderline lung function may have better survival as compared to lobectomy, particularly in stage 1 group. Thank you very much.
Thank you for your presentation. I'm just switching to Slido, sorry. Another app, Slido. So there are no questions so far. Can I just ask you to comment on the length of stay that was, in one group about 14 days, and if I remember correctly, 13.8. What was the leading cause for this length of stay?
Most of the most commonly common cause that we found was because patient who went into the ICU requiring prolonged oxygen requirement or ventilation. I think there was only 1 or 2 patients who had post-operative infection, but basically it was respiratory support that was required, and they went to the ICU and that prolonged the stay.
Do you have in your own unit HDU?
We do have.
And would this patient go to the ITU for ventilatory support for non-invasive, or?
For non-invasive, they can come to high care, but if they need intubation, invasive ventilation, then they have to go to, of course, they have to go to ITU.
Yeah, but my question was, they would first go to HDU and then maybe escalate. Okay.
Of course.
All right.
Yeah.
So we have some audience questions coming in, one of them is about quite consistent with the recent RCTs presented last week. It's coming from Chris Satter. What preoperative strategies were used for these patients, and will sublobar resection be used to extend resection rates? Now, I'd like to add a little bit to that question as well, because I was thinking in those lines. You said a lot of your patients were smokers. Did you follow any of the prehab principles or enhanced recovery principles? Number one. And number two, you sublobar resection. In your abstract, you had 45.9% sublobar, of which 36% were wedges. So is it true that only 9.2 were anatomical segmentectomies?
You are correct. There were 9.2% were anatomical segmentectomies, and the rest were all wedge resection.
So you can't really use this as similar to the recent AATS paper presented, which was more looking at anatomical segmentectomy and for early stage cancer and lung function. But thank you so much for your presentation.
No,
please keep rating the presentations. Please keep putting questions on Slido. In the interest of time, further questions will be put on the chat section for Adnan to answer. Thank you, Adnan.
Thank you very much.
Helen, over to you.
Thank you, Helen.
Okay, so our next presentation is by Veena Surendra Kumar, and she's going to talk to us about quality of life following lung resection surgery.
Good afternoon. Many thanks for giving me the opportunity to present our data on quality of life following lung resection. It has now been recognized that quality of life following surgery is an important consideration for patients making a decision about proceeding with an operation. However, this can be often overlooked post-operatively in favor of clinical outcomes including resection margins, recurrence, and survival. This is significant as the likely effect of surgery on a patient's quality of life should form a key part of the pre-operative consent process. The aim of our study was therefore to evaluate the short-term impact of lung resection on quality of life over a 10-year period in a single tertiary thoracic surgical unit. We set about identifying all patients undergoing lung resection at Birmingham Heartlands Hospital between 2010 and 2020, who were recruited as part of an ongoing prospective study. Assessment involved completion of the European Organisation for Research and Treatment of Cancer QRQ-C30 and Lung Cancer 13 questionnaires preoperatively and postoperatively at 6 weeks and 5 months. Further information was reviewed retrospectively on patient demographics, preoperative investigations, operation details, and surgical complications. Pre- and post-operative data was collected from 1,011 patients, of whom 732 completed all 3 questionnaires. Mean age was 68 years with an equal gender split among patients. Mean predicted pre-operative FEV1 was 87%, and 69% of patients were ex-smokers, with 17% of all patients undergoing some form of pulmonary rehabilitation, either pre- or post-operatively. Lobectomies were performed in 67% of cases, and 60% of all operations were completed via VATS. Mean length of stay was 5 days, with a range of 1 to 29. Patients reported a significant deterioration in global quality of life scores in the 6 weeks following surgery, which was maintained at 5 months post-operatively. A significant decline in physical, social, and role functioning was also seen at 6 weeks, and although this improved by 5 months, still remained significantly below pre-operative levels. Symptoms of dyspnea, fatigue, and pain also worsened following surgery. However, pain did appear to improve significantly towards baseline in the longer term. A significant correlation was seen between percentage predicted pre-operative FEV1 and overall global health scores at 5 months. This was also true for the domains of physical functioning, role functioning, fatigue, and dyspnea. Age at time of surgery significantly correlated with emotional functioning and pain at 5 months post-op, but did not affect overall global health score. Length of stay, however, did have a significant influence on most quality of life domains at 5 months. In conclusion, lung resection has a significant impact on post-operative quality of life for patients. To our knowledge, this is the largest dataset of patients undergoing lung resection with quality of life follow-up data, the results of which not only emphasizes the often overlooked impact of surgery on quality of life, but highlights the importance of accurately counseling patients on this perceived deterioration in symptoms and daily functioning. Further research is required to see whether this deterioration in quality of life improves over a longer follow-up period, and what pre-operative interventions may help mitigate this decline. With many thanks.
Thank you very much, Veena. So while we just wait for some questions to come in from the audience, I know the aim of your study was to look at short-term outcomes. Do you have any plans to extend the length of follow-up and look at longer-term outcomes and see if these patients do return to normal functioning?
Not in this particular study, but I agree that I think in the long term, what's happening over the longer term is important. There are some studies out there that say actually quality of life, even past a year, doesn't quite return to baseline. And I mean, our group was quite heterogeneous and we're still doing the further sub-analysis. So there's quite a few patients, but it would be, a lot of these patients go on to have chemotherapy, and as has been talked about plenty of times in this conference, immunotherapy is coming across. So, all that will affect quality of life post-surgery. So it'd be important, even with a longer follow-up, to try and delineate those groups.
Okay, and then a couple of questions coming in along a similar theme of, are you planning any sort of subgroup analysis comparing sublobar resections with lobar resections, or VATS with open to assess how that affects outcomes?
Yes, so we have all that data. As I said, it's quite a big data set, and so we're just hopefully we're in the process of analysing that. And like I said, it is quite a heterogeneous group. So there are patients who went on to have adjuvant chemotherapy, that, you know, looking at those groups and those, you know, who are considered higher risk, or importantly, those who've had rehabilitation in some form, either pre or post-operatively, and how that impacts their quality of life.
Okay, excellent. If we move on to the next presentation.
Thank you.
Yes, it's my honor to introduce the next speaker, Tom Kamalek, that will talk to us about should trainees perform high T-stage lung resections, a single center experience. Thank you.
Hi, my name is Tom Kamalek, and I'm one of the thoracic trainees in the University Hospital of Wales, Cardiff. I'd like to say a special thank you to my consultants for allowing me to present this work, looking at whether trainees should perform high T-stage tumour lung resections based on our single centre experience. We have a very strong training ethos in our centre, and we hypothesise that even relatively junior surgeons, whether they are NTN trainees or non-NTN, perform satisfactory lung resections in advanced tumours, obviously with the appropriate supervision and training. The purpose of our study was to assess whether patients who have operations performed by trainees experience worse outcomes relative to those completed by consultants. We performed a retrospective review of all thoracic surgery patients in our centre. We looked at a 2-year time period starting in October 2017, and we identified patients through the PATS patient tracking system and correlated this with our theatre system, TheatreMan. We assessed preoperative stage, Thoraco score, the operation and operative time, length of stay, and mortality. We identified over 1,000 procedures via PATS, and of these there are over 250 anatomical lung resections for primary lung cancer, with a documentation of preoperative stage. When we look at the mortality, we can see there are only 3 cases, 2 for the consultants and 1 for the trainees, and this is what we would expect based on the national statistics. And we can correlate this with Thoraco score. Whilst I appreciate it has significant limitations, it gives us an idea as to the complexity of these patients and their perioperative risk. When we look at the operations performed, the majority of these patients have had a lobectomy, especially in the T1 to T3 groups. However, there were a handful of pneumonectomies and bilobectomies. As you can see, the percentage performed by trainees remained fairly consistent across the T stages at approximately 60%. The number completed via VATS is similar between the consultants in blue and the trainees in orange, running at approximately 80 to 90% for T1, running down to about 70 to 80% for T3, with a trend towards slightly more performed via VATS by the trainees compared to the consultants. T4, as we would expect, is a much lower completion by VATS rate. When we look at VATS converted to open, only a handful of cases were started by VATS in the T4 group, and these were probably primarily for assessment prior to conversion to open, although the reason for converting is not documented. We can see there's a slightly higher rate of conversion to open in the T1 and T2 group by the consultants, but overall quite similar trends. When we look at the procedure times, we can see there are similar procedure times throughout at approximately 3 to 3.5 hours for most of these cases for the consultants, and 2.5 to 3.5 hours for the trainees. It's important at this point to note that when consultants have a longer operative time, this may be because the trainee has started the case and a consultant has completed the case, or the consultant has had no trainee available and has an inexperienced assistant. However, all that being said, we can see that the T1 group is slightly longer operative time than the T2 group, and this is likely to be due to the higher frozen section rate. I say it is unclear how many consultant-completed cases were started by a trainee. Looking at length of stay, again, consultants in blue and the trainees in orange, we can see that there is one spurious group in the T4 consultant group who has a much longer length of stay. There's only a handful of patients in this, and that is most likely what has led to the skewing of the data. However, in the trainee groups, we can see they've consistently got a median length of stay of 5 days, which is excellent. And this is similar to the consultants in the other groups. So overall, we can see that trainees have completed operations and had similar procedure length of stay, and mortality at every T stage. And in fact, there's a trend suggesting that maybe they are quicker. However, we need to be careful how we interpret this. So the further questions are in terms of how significant is the phenomenon of an expert assistant, as the majority of these trainee completed cases had a consultant supervised scrubbed, and the consultant completed cases may never have had a trainee with them. Which cases were started by a trainee and completed by a consultant? It is not clearly documented and has almost certainly led to significant bias in what we see in the results. It'd be nice to know exactly what were the detailed intraoperative and postoperative complications for these patients. Thank you very much for your time, and I'm happy to take questions.
Just a quick point. I mean, I think your remark about the lack of clear data, in which suggesting that many years of experience making operators lower, there's certainly something missing in the data you have pulled out. Because in my experience, I have no experience of consultants being an hour slower than their trainees in performing procedures. I mean, it's something that probably just further digging into the data would clear at this point. And I'm just switching to see if anything on Slido.
So yeah, I think there are some questions coming through, but can I please request everybody to rate the presentation as well as put questions on, please? I know there are quite a few people watching. So one of the questions, do you want to read it out, is an interesting one from Oliver Harrison.
So it's a great presentation. It's a big data set. We'd be really helpful to have an algorithm to predict likely impact of the procedure on quality of life.
No, sorry, that's from the previous one.
This training looks great. Apologies if you mentioned but where the level of the trainees, what was the level of trainees, how many were they, and they did, it basically ask you what stage of training were the trainees and when they were performing the procedure. And obviously the consultants were allocating the cases according to the level of training of the trainees. Well, if you can comment on that.
So the majority, so the trainees, the NTNs, there were 2, and they were during that data set between ST3 and ST6, and there were also 3 non-NTNs with a range of experience, but that's fewer of the cases, are probably about 20% they were involved in.
So there's an interesting question from Adrian Marchbank saying, would you describe this as non-inferiority? Any comments?
Exactly. No, just to stress that point, that in no way are we suggesting that the trainee group are completing cases quicker than the consultants. I think, as you've clarified, and I hope I've elucidated, that there are gaps in the data in terms of the databases don't capture when a trainee has started a case and perhaps run into difficulty, or when there's a lot of adhesions and then converted to an operation with the consultant finishing the case. At the end of the day, it goes down as a consulting case.
I mean, these type of studies will always have a bias in it because there is a consultant that always will decide the cases to be allocated. So it
it's
will always be
commendable.
But certainly the fact that not having worst result is important. That was the point. That is well
and the proportion of training is really commendable. Anyway, in the interest of time, further questions are on the chat box. Please do keep posting them. The next presenter is Hesham Ahmed, who's going to talk to us about time from referral to treatment. Does it affect the outcome of lung cancer patients undergoing surgery? Thank you.
Hello. It's a great honor to me to be with you today in SCTS annual conference and to present you Time from referral to treatment. Does it affect the outcome of lung cancer patients undergoing surgery? This study was done in Nottingham University Hospital and presented by me, Hisham Ahmed. Objectives. The National Optimal Lung Cancer Pathway is to be implemented across the UK, aiming at reducing the time of management of lung cancer patients. We studied the effect of referral time from GP to treatment, RTT, on our group of lung cancer patients who were surgically treated. Methods. A retrospective study of prospectively collected data included 700 patients diagnosed with lung cancer who underwent surgical resection between 2010 till 2019, referred to us from one center. Those category of patients were operated in Nottingham University Hospital and had their follow-up in Nottingham University Hospital as well. RTT was categorized into two groups, Group A, who had treatment within 49 days, and Group B, who had treatment in more than 49 days. Propensity score matching was used to eliminate any clinical bias. 414 patients out of 700 patients were matched. Analysis was performed to evaluate the effect of RTT on overall survival, disease-free survival, and the development of recurrence. In our result, mean age in Group A was 65.6 and in Group B was 66.9 years. Mean of RTT was 72.5. As we see in the diagram, our RTT has marked improvement from 77 days in 2011 to 62 days in 2019. In our results, 140 patients were in Group A who were operated within 49 days, and 274 patients were in Group B who were operated in more than 49 days. Distribution of both groups were the same. Surgical resection according to the stage. There was no significant difference between stage 1, stage 2, and the stage 3, and distribution of surgical resection as well regarding to sublobar resection, lobar resection, and pneumonectomies. Our result before propensity score matching. 5-year survival was 69% in Group A and 52.5 in Group B. B-value was 0.009. After propensity matching, overall survival in Group A was 85.1 months, while in Group B was 80.4 months, and 5-year survival was 69% in Group A and 61.5 in Group B, and B-value was 0.2. In stage 1, 5-year survival was 73.8% in Group A and 64.1 for Group B, and B-value was 0.14. In stage 2, 5-year survival was 63.8% in Group A and 49.6% in Group B, and B-value was 0.9. However, in stage 3, 5-year survival was 61.7% in Group A and 30.1% for Group B, and p-value was 0.03. Overall survival of cancer subtypes. 5-year survival for adenocarcinoma was 65.7%, and for squamous cell carcinoma was 59%, and p-value was 0.6. Does RTT affect the outcome according to the pathological subtype? According to the Kaplan-Meier curve, for adenocarcinoma, there was no significant difference between both groups. B-value was 0.6. However, in squamous cell carcinoma, there was weak significant difference. B-value was 0.06 between both groups. Recurrence occurred in 20 0.9% in Group A and 27% in Group B, and p-value was 0.08. There was no significant difference in disease-free survival between the two groups, and p-value was 0.5. For conclusion, operating on patients within 49 days from referral resulted in favorable long-term survival, especially in patients with pathological stage 3 non-small cell lung cancer and in patients with squamous cell carcinoma. In our cohort, there was a tendency to less recurrence of cancer in this group of patients who were treated early. These results support the implementation of the new optimal lung cancer pathway and make a case of prioritizing operating on patients with stage 3 non-small cell lung cancer. Thank you.
Thank you very much for that. Very pertinent because we're all going to have to adhere to that time frame. It appears only 20% initially were achieving on the whole group. Some very interesting questions. One from Kieran McManus: did you restage any patients when their delay was getting long? Can you, sorry, Hisham, are you with us? Can you hear us? I think we may have lost Hisham at the moment. And in the interest of time, I am going to request Helen to move on to the next speaker, please.
So our next speaker is Rashmi Purmasa, who's going to speak to us about the delay between staging PET and resection of lung cancer. Does extra theatre capacity make a difference?
Good afternoon, everyone, and thank you for your attention on the last day of the SCTS Annual Meeting 2021. My name is Rashmi Purmasa, and first of all, I would like to thank the SCTS organizers for the opportunity to talk about the impact of delay between staging PET and surgery on predicted long-term survival of patients with early-stage primary lung cancer. The initial concept of a 62-day period between referral from a general practitioner to surgery or first treatment was introduced by what is now known as NHS England in the NHS Cancer Plan in 2000. In 2015, NHS England created the Independent Cancer Task Force, who published a strategy to achieve world-class outcomes with the aim of improving UK survival rates in cancer patients. As part of a strategy, they also reinforced the idea of having a maximum delay of 62 days between referral to treatment. In 2010, the British Thoracic Society recommended that contemporaneous imaging was necessary, and that the latest imaging, most commonly a PET scan, had to be less than 4 weeks old when considering radical treatment for borderline lesions. Why were these recommendations made in the first place? As shown by a study published by the International Association for the Study of Lung Cancer in 2016, the 1-year and 5-year predicted mortality rate increases significantly with every upstaging. And therein lies our aim. We sought out to understand, in our institution, what is the impact of a delay between PET scanning and surgery on the predicted long-term survival of patients. To start off, how contemporaneous were the images? And then, did the tumor actually progress with increasing delays? And did this then cause a decrease in the predicted long-term survival? As our study progressed, we then determined whether increasing the availability of theatre slots made any difference to the predicted long-term survival rate of patients. We carried out the first audit cycle from January to August 2018. And went through all available clinical notes and imaging systems and compared the predicted survival based on preoperative investigations clinical staging to the final histopathological staging. We then repeated the process from May to December 2019 when the theatre slots were increased. In our first audit cycle, 59% of patients were upstaged. As you can see on the chart here, in the total number of patients, The patients who were eventually upstaged had a higher mean number of days delay between PET scanning and surgery. Patients with a more than 70-day delay between PET scanning and surgery were more likely to be upstaged. Overall, the decrease in predicted survival was 10% as compared to the decrease of 17% in predicted survival in patients with upstaged cancers. What was our intervention? After presenting the results of the first audit to the management board of our institution, we were allocated 31% more theatre slots. We then sought out whether this would actually impact predicted long-term survival of our patients and repeated the audit. As you can see, increasing the theatre slot caused a shift of patients towards having earlier curative resections. And it did have an effect on the percentage of patients whose cancers were upstaged, 59% in round 1 and 28% in round 2. As we also noted an improvement in the predicted long-term survival for our patients with a decrease in predicted survival of 4% overall as compared to 10% and 14% as compared to 17% in patients whose cancers had been upstaged. We can therefore conclude that delays between PET scanning and surgery do have a significant impact on the predicted long-term survival of patients with early-stage lung cancer. Delays of more than 70 days are more likely to result in upstaging of a tumor, and the provision of extra theatre slots had a positive effect on the predicted long-term survival of our patients. Thank you for your attention, and I welcome any questions you may have.
No, you go for it.
So just off the bat, can I ask you, Rashmi, when you, maybe I missed it, but the upstaging was radiological or pathological?
So the initial staging was done using the PET scan. That was the pre-op staging, and that was the radiological staging. But the final staging was the pathological staging in the actual specimens that we took out to the patients.
Did they concur, the results? The radiological upstaging concurred with a pathological upstaging?
No, so the upstaging was comparing the pathological staging at the time of surgery as compared to the radiological staging in the PET scan that happened preoperatively.
Okay.
So that's what we are comparing, was that the fact that even though, say, they were a T1 tumor at the time of PET scanning, they were then a T2 tumor at the time of taking the actual lobe out.
Okay, thanks.
That's very, very interesting,
Very
Rashmi.
good.
Thank you. While I would encourage people to put questions in the chat box, please also remember to rate the presentation. One of the points I noticed is on the abstract, you said 31% were upstaged on your second count. Sorry, 28%. That's even after increasing your availability. That's quite a high number. How do you explain that? And sorry, the second part is, of the ones that were upstaged, did you look at them to see if, I think this is what Francesco was trying to get at, if they were distant metastases or if they were local, regional or nodal metastases?
So in terms of the post-operative staging that we did, we looked at the specimen that we took out. We didn't do we didn't look at the radiological imaging that happened 6 months down the line. We were looking only at the radiological imaging that happened before surgery as compared to at the time of surgery, not after surgery. That's what we were comparing.
Okay.
Your first question was that, yes, even though we did increase the number of theatre slots, there still is a certain amount of delay that happens between the PET staging and the actual surgery as well, which we're trying to minimize as much as we can. But given the resources in the NHS, we have to work with management. Yes,
indeed. I think you have some more useful information. I think Kieran McManus has put there, can you talk to our management, please? Which is true. We all have our head bangings against, and I hope you get some more information to go back, because you've demonstrated a very good improvement from your 2019 presentation. So hopefully in a couple of years, we'll be coming back to see how much better you are at this, to try and convince your management or change the team maybe. In the interest of time, I think we move on to Francesco. Do you want to introduce the next presenter, please?
Yes, we have a talk from Marcus Taylor. Can measures of systemic inflammation accurately predict short and long-term outcomes after lung resection?
Please ask the questions during the presentation, and please rate the presentation. Thank you.
Good afternoon. My name is Marcus Taylor, and I'm here on behalf of the Northwest Thoracic Surgery Collaborative, which is a research group comprising clinicians from Manchester and Liverpool, to present our work on the impact of measures of systemic inflammation and their ability to predict outcomes after lung resection. Now, the biology and pathophysiology of cancer has become increasingly well understood in recent years, and as part of that research, the role of inflammation in the development, propagation, and progression of cancer has also become increasingly well understood. And as a result of this, the impact of individual inflammatory biomarkers such as the white cell count and the platelet count have been investigated for their ability to predict long-term outcomes. Further work on this has allowed several of these biomarkers to be combined together to produce inflammation-based scores. And again, these have been looked at for their ability to predict outcomes, predominantly long-term outcomes, but a few have looked at short-term outcomes as well. So the aim of this study was to use our large volume contemporary patient database to review the ability of a number of these biomarkers and scores to predict short, mid, and long-term outcomes for patients with primary lung cancer undergoing lung resection. So 5,029 patients underwent lung resection for primary lung cancer between 2012 and 2018 at Manchester University NHS Foundation Trust and the Liverpool Heart and Chest Hospital. We reviewed 6 different measures of systemic inflammation, and as short-term, mid-term and long-term outcomes, we looked at 90-day mortality, 1-year mortality and overall survival, and we did our univariable and multivariable analyses using SPSS. So the 6 scores we used were the neutrophil to lymphocyte ratio, the platelet to lymphocyte ratio, the advanced lung cancer inflammation index, which combines inflammatory and nutritional variables, the prognostic nutritional index, which again combines inflammatory and nutritional indices, the systemic immune inflammation index, which is a combination of the variables in the neutrophil to lymphocyte and platelet to lymphocyte ratio, and finally the hemoglobin albumin lymphocyte platelet score, the most comprehensive of all, which includes 4 of those variables. So these were the different variables that we included in the multivariable analysis. In order to avoid collinearity, any of the scores that included BMI and albumin, BMI was not included separately in the multivariable analysis, and the same for the HELP score, which included anemia. Hemoglobin anemia was not offered as part of the multivariable analysis. So what you can see on univariable analysis, when you look at patients alive at 90 days and patients dead at 90 days, you can see that with the exception of 2 of the scores, all of the scores were predictive of 90-day mortality. The same was seen at 1 year, with the exception of the HELP score. There was a significant difference in the mean value of these scores when you look at patients who were alive compared to patients who were dead. We then did multivariable analysis for each of the 3 primary endpoints. So you can see at 90-day mortality, 5 of the 6 scores were significantly associated with higher 90-day mortality after multivariable analysis. And the only one that wasn't was the prognostic nutritional index. When you look at 1 year, you see a broadly similar thing. All that's happened is the hemoglobin albumin lymphocyte platelet score has lost significance and the PNI has gained significance. The other 4 scores remain significantly associated with higher 1-year mortality. And then for overall survival, with a median follow-up time of 33 months, 4 of the scores remain significantly associated with reduced overall survival. So what we've shown is that measures of systemic inflammation are linked to adverse outcomes after lung resection for lung cancer patients for short, mid and long-term outcomes. The neutrophil to lymphocyte ratio, platelet to lymphocyte ratio and systemic immune inflammation index all emerged as being significantly associated with worse outcomes for all three of the primary endpoints. And therefore, we feel that these variables should be considered when clinicians are risk stratifying patients referred for surgery. Thank you.
Thanks, Marcus. That was really interesting. Just a first question that comes to mind is, have you actually started looking at this prospectively in your unit?
So not yet, but we're currently in the middle of doing something on a super-regional level with a number of different centres, some of which will include prospective data, and where possible, we're hoping to collect some of these variables, yes.
Yeah, I mean, also because the work needed, apart from developing algorithms to calculate this, could be embedded in the softwares of the hospitals. I mean, it could come out, you know, without even having to calculate it. So that would be very, very interesting. Even add to an MDT, for example.
Yeah, absolutely. And I think, you know, things like Thoracoscore are inherently built into a lot of these platforms these days, and that's the sort of thing that could be considered. Yeah.
No, very interesting. Thank you. So let's see. Slido.
Thank you, Marcus. This is a very, very interesting stage. I think it sets the stage for further and better quality UK population risk assessment for thoracic surgical procedures, which I think is something that's a future of the project. Is that correct?
Yeah, no, that's absolutely right. We're looking at modelling in general. And so, yeah, we'll be using sort of large-scale databases from retrospective and prospective databases from across the UK for exactly that reason, to try and come up with some better quality outcomes about risk modelling.
And just a question on, so you looked at 90-day mortality. Mortality is becoming a rarer incidence in thoracic surgery, and people are looking to other parameters like morbidity, I suppose length of stay is a surrogate, quality of life. Do you have any intention of using this to calculate post-operative morbidity? Because you'll have a larger data set of patients that undergo that, and the prediction of that and length of stay would have good implications on planning resources.
Yeah, I think that's a really important point. And I think certainly the outcomes in the literature in the last few years have very much shown that 90-day mortality is double 30-day mortality after lung resection. And so not only does 90-day mortality perhaps better reflect perioperative mortality, it has the statistical benefit of having a greater number of outcomes. We haven't done a huge amount of work with our group yet in terms of morbidity outcomes, although that is something that we're thinking about looking into. And I definitely think in the fullness of time, we'll compare morbidity to mortality in terms of accuracy of these systems.
Thank you very much, Marcus. There might be questions waiting on the chat box. Can I please request listeners to rate the presentations and to keep coming with questions? Marcus, thank you very much. Helen, do you want to introduce next, please?
So the next presentation is regional variation in lung cancer stage at an Irish Rapid Access Lung Clinic, and it's presented to us by Gaith Kushos.
Hello. I am Dr. Gaith Kushos, a cardiothoracic registrar from St. Vincent University Hospital. Today, my talk will be about the regional variation in lung cancer stage at an Irish Rapid Access Lung Clinic. Lung cancer in Ireland is the most common cause of cancer death, with most patients are diagnosed at an advanced stage. Literature shows that people who live far from treatment centers may have a lower rate of surgical interventions. This impacts outcomes, even controlling the area level deprivation or patient financial status. In Ireland, the Rapid Access Lung Clinic provides equal access to diagnostic and treatment. Once a patient attends the clinic, they have a common audit pathway with equal access to the same radiology, pathology, decision-making in MDT and treatment. The aim of this study is to assess if regional variation in lung cancer presentation persists in the setting of the common diagnostic and treatment services. This is a retrospective study. Study included 152 patients. All patients included underwent surgical resection with a curative intent. Pathological data was explored for tumor size, tumor type, nodal status, and stage. We excluded patients with unresectable cancer or stage 3 or 4. This study evaluates the St. Vincent's University Hospital Rapid Access Lung Clinic, which serves a high-density urban population in County Dublin and Wicklow, as well as lower density and more rural population in counties as Kilkenny, Carlow, and Wexford. Patients were divided into 2 groups based on distance from the treatment center in Dublin. Group 1, including the closest patients from Dublin and Wicklow, with 97 patients. Group 2 included patients who were referred from away from lower density regions, included 55 patients. In the results, we see that adenocarcinoma, it was more common in group 1 with 65% comparing to 29 in group 2, while squamous cell carcinoma, it was more common in group 2 with 30.9% comparing to 21%. Lung cancer stage, it was significantly more advanced in group 2, in stage 2 and stage 3. Also, the tumor size, it was significantly larger in group 2 compared to group 1, with 31.7 millimeter in group 2 to 24.7 in group 1. Nodal status, it was more advanced in group 2 with more N1 and N2, but without significant p-value. In the results found here, we see that patients with primary lung cancer living in lower density parts of Ireland present at later stages. Lung cancer mortality is high because the majority of disease is discovered at an advanced stage. Therefore, an understanding of any factors which influence the stage at presentation could assist in optimizing outcomes. The National Cancer Registry in Ireland for 2016 reported that the incidence of lung cancer is higher in the urban area compared to the rural area. On the other hand, they found that the majority of patients from urban areas presented with early stage lung cancer compared to the rural area. In this study, we see that this is not the result of access to diagnostics or treatments. Patient-specific factors related to awareness of symptoms, self-referral, opportunistic interactions with the health services, and access to the local health facilities may be contributors. In conclusion, removal of regional variation in cancer outcomes is a national health goal. Unfortunately, in Ireland, such variation exists. We have shown that the key factor is the patient status at the time of presentation rather than access to diagnostics and treatment. This may help focus efforts at this phase in patient self-presentation and opportunistic interactions with their local health services, improving the connections with the rapid access lung clinic treatment centers may diminish these urban-rural differences in treatment and survival. Thank you.
Thank you for your presentation. So there are a question at present. I think that is important to remark these findings or regional variation. I think it's common experience for surgeons that have a broad referral base that unfortunately patients coming from rural areas tend to present with delayed diagnosis. So is there any program that you guys are implementing to raise awareness of symptoms and earlier referral?
There is no specific program, but the Rapid Access Lung Clinic itself, it's offer equal approach to the treatment and diagnosis in whole Ireland, in the whole country. But there is no specific program for awareness itself, no.
think that fits in very nicely with a question that Kieran McManus has asked about urban patients having a higher incidence of adenocarcinoma being picked up incidentally or through screening or health check services. So I think you kind of answered that. Have you got any more comments to make? And the additional point is, how are you going to take this forward to help raise the awareness? Because there is regional variation even in NHS England, but there are steps being taken to address that. So how are you going to use your information to go back and improve or help to improve the services?
First of all, I think we need to identify the causes of this variation. Like it's the delay in referral, or it's in delay in presentation to GP who refer patients to the treatment center. So I think we need to start awareness program in the country, especially in rural counties, to introduce, to educate more about symptoms, about early awareness about the symptoms and the presentation to the GP, who will refer them to the treatment center. So I think most important thing to start awareness campaign about this thing.
Yeah, and how about national, following the national optimal lung cancer pathway and speaking with commissioners? Would that be a two-prong approach? Is that something that's been considered? I'm sorry,
yes.
Excuse my ignorance. Please comment.
Yes, also, of course, that can be considered. And
is it being done?
Yeah, not yet.
I think there is a very good example from NHS England and the 62-day targets being pushed to 49-day targets, and I think something like that with and involvement with the commissioners will help push things forward and raise awareness with the things that you're doing. Thank you very much for your presentation.
Thank you.
And I would request, actually, Francesco, do you mind just announcing the next one, please?
I thought it was your turn. All right.
Is it? I'm sorry, Helen did the last one. Helen, if you can go for it.
I can do this one. So our next presenter is Nicole Asamoah, who's going to talk about the implementation of preoperative pathway for assessment of indeterminate thymic lesions.
Hello, my name is Nicole Asamoah. I'm a junior doctor at St Bartholomew's Hospital in London, and I'm here to present to you today the review into our implementation of a preoperative pathway for assessment of indeterminate thymic lesions. There are many challenges with the management of thymic lesions, including determining the correct surgical approach, with increasing evidence, including results from our own institution, demonstrating the benefits of minimally invasive surgery over open median stenotomy. However, even with improving surgical techniques, accurate diagnosis of benign versus malignant disease is paramount. Thymic lesions are most commonly imaged initially with CT. Some of these lesions are deemed as indeterminate, with an inability to distinguish between benign and malignant disease. Most often, these lesions will ultimately be resected, with benign lesions only identified post-operatively. As such, it was identified that 44% of thymectomies performed in 2015 were non-therapeutic, that is to say, for benign lesions. MRI remains largely reserved for those unable to have a CT scan, for example, kidney disease or iodine allergy. Use of MRI for imaging of thymic lesions has many advantages. MRI is known to have a greater specificity for accurate diagnosis of thymic lesions, particularly for distinguishing between thymic cyst, thymic hyperplasia, and thymoma. Furthermore, additional MRI protocols are available to further delineate benign from malignant disease. That most often described, and the method used within our hospital, is the chemical shift method. This involves imaging of the lesion in two different phases, as demonstrated in figures 1 and 2, and comparing the attenuation of the thymus between the two images. Using these values, radiologists are able to calculate the chemical shift index score, or the CSI score, with scores of less than 0.8 denoting benign disease, and those greater than 0.9 suggesting malignant disease. Figure 3 demonstrates an example of this, highlighting a thymic lesion with a CSI score of 0.3, suggestive of benign disease. We therefore introduced a pathway to incorporate the MRI in the management of indeterminate lesions in our hospital. Within our units, patients initially have a CT scan, and those with lesions resembling thymoma undergo PET scanning and surgical resection. However, indeterminate lesions would often go to MDT and ultimately be resected for fear of missing malignant disease. This practice is not uncommon, with outcomes from Massachusetts General Hospital in the USA demonstrating similar pathways. In 2018, the MRI was included to further delineate indeterminate lesions. These lesions were divided between solid and cystic lesions. For solid lesions in particular, the CSI score played an active role in determining the ultimate management of these lesions, as demonstrated in this diagram. We have retrospectively analysed our outcomes pre and post MRI implementation over a 22-month period. We reviewed outcomes including MDT discussion, MRI results, and post-operative histology. Our aim was to demonstrate that the introduction of MRI reduced the rates of benign resection. However, we also acknowledge that accurate and adequate diagnosis of malignant disease must be maintained. We had 88 patients in our cohort with a similar split between the pre and post MRI groups. The average age was 49 years, with a greater proportion of women in both groups. 10 patients had a known diagnosis of myasthenia gravis. Looking briefly at initial investigations, MRI already begins to show benefit, with 20% less patients needing PET scanning and associated additional radiation, and no requirement for additional invasive diagnostic procedures. The most clear benefit of additional MRI testing is in the reduction in those undergoing surgery. Our unit demonstrated a clinically significant 64% reduction in patients undergoing surgery from 42 to 21 patients. This carried forward into reduced critical care admissions for non-myasthenia gravis patients and less post-operative complications. Of those that did undergo surgery in each group, the detection of benign disease was also significantly smaller in the post-MRI group, with only 7 or 13% of the post-MRI group having benign disease resected, compared to 60% of the pre-MRI group. However, of the 7 benign patients in the post-MRI group, 4 were inappropriately deemed malignant on MRI. This highlights potential pitfalls and limitations to its use, with CSI scores of 0.7 to 0.9 still deemed indeterminate, and lesion content, including calcification, septation, sclerosis, and malignant on benign disease, skewing potential diagnoses. Lastly, we maintained adequate detection of malignancy, with 71% of malignant MRI lesions being true malignant disease histologically. Again, this was proven to be clinically significant. In summary, MRI can be accurately used in clinical practice to delineate benign and malignant disease and reduce benign resection rates, whilst maintaining adequate resection rates of malignant disease. Cross-collaboration between thoracic surgeons and radiologists is required to facilitate its use in the pre-assessment of indeterminate.
Very much for your presentation. Just first question that comes to mind: do you have in your unit for this study radiologists who are dedicated to this, MRI, thoracic MRI, and the study of this? There was some specific interest group before you started all this.
We have a few radiologists that have been working quite closely with the surgeons that perform the thymectomies within our institution, and they are sort of helping and working with the surgeons to champion this and progress it forward. And in fact, we've had some modifications to the algorithm since then, based on increased experience and use of the program.
And have you had some sort of conversation, maybe at a more senior level than yours, at costs of running MRI programs for long lesions? Have they raised this point?
I'm not sure if they've raised them themselves specifically. I have had sort of very brief conversations myself, just with the surgeons themselves. And however, we have come to the conclusion that overall there is a risk, there is a cost toward doing these additional MRI scans, but that may necessarily be offset against the cost of additional operations and recovery and post-operative morbidity for those who don't necessarily need an operation. And have you followed up the patients that you decided not to operate on the basis of their MRI and seen whether they do they have any system of follow-up scans to see whether they later need surgery, and how many of those do eventually turn out to have a malignancy? Yes, so all patients who are deemed benign and don't get operated on will have a repeat MRI in 12 months and then get rediscussed at MDT. So we haven't quite reached the 12 months for most of these patients yet, and then naturally things the current pandemic situations prevailing. So we're in the process of collecting our results for that, and hopefully that will come back together and we can review those results. Excellent.
Nicole, thank you. Thank you very much, Nicole. Excellent presentation. There are some other interesting questions coming up on the chat box. I would request you to go and answer them so that we can respond to the interest. In the interest of, so thank you very much. In the interest of time, just to remind everybody, please keep rating the presentations and please keep asking the questions, especially during the presentation. So I'm aware we're running a little bit late, but in the interest of time, I'd like to introduce our next speaker, who hardly needs an introduction in the world of thoracic surgery or in the world internationally. It's the one, the only Mr. David Waller, who's going to talk to us about less is more, the future for thoracic surgery. Mr. Waller.
Good afternoon. My name is David Waller. I'm a consultant thoracic surgeon at St Bart's Hospital in London. I'm grateful to Melinda Calcat for giving me the opportunity to give this extra keynote lecture at the Society of Cardiothoracic Surgery virtual annual meeting in 2021. My title is The Future of Thoracic Surgery. Unfortunately, that doesn't refer to me. The future of thoracic surgery is that less is more. Why am I giving this extra keynote lecture? This is in response to the fantastic recent presentation at the AATS in Seattle of a randomized trial comparing segmentectomy to lobectomy in small peripheral non-small cell carcinoma, the JCOG 0802 trial, presented by the current president of ISLC, the lead surgeon, Hisao Asamura. This trial has significant implications for our practice, which I will consider in the next few minutes. I'm also talking about this because of the increased support for lung cancer screening. The Nelson trial showed a survival benefit from CT screening in high-risk populations, and this is now being rolled out into local screening programs across the United Kingdom. We are identifying more of these so-called subsolid pulmonodules, which can be broken down into those that are pure ground glass or the part solid nodule. There is hoped to be some correlation between the radiographic appearances and the pathology. As you can see there at the bottom, the part solid nodules may contain minimally invasive adenocarcinoma prior to the development of a pure solid lesion. Just a brief comment on when we shouldn't operate. I don't believe the evidence supports operating on pure ground glass nodules, since the growth of the residual nodule, development of new nodules, or whether or not all ground glass nodules were treated, has not been found to affect survival. And there is a significant difference in 5-year survival between the ground glass nodules and solid nodules, with a ratio of the solid component greater than 50% of the lesion. I do think we should operate when the solid component becomes visible, and this may entail a wait for volumetric growth of the nodule over a 3-month period. That is not always helpful, particularly when the solid component is less than 8 millimeters in diameter. There can be a problem in finding these early screen-detected lung cancers. They may be too far away from the surface or too small to digitally palpate with the finger. They may be difficult to locate percutaneously. You may have seen previously in the meeting demonstrations of the use of the hybrid operating theatre for CT-guided localization techniques and the use of navigational bronchoscopy. I will consider in this talk the use of near-infrared thoracoscopy and also the use, in conjunction with the findings of the JCOG trial, of diagnostic segmentectomy. Because it was considered that lobectomy was still the gold standard up until a couple of weeks ago. The lung cancer study group trial was conducted 25 years ago, and although it showed a benefit in terms of overall survival for lobectomy against limited resection, the clinical and staging assessment has changed significantly since those times, and there have been advances in surgical techniques, of course. And in this trial, the experimental arm included wedge resection, and very few segmental resections were performed. So, what is this JCOG 0802 trial all about? This was a trial looking at clinical stage 1A, proven or suspected lung cancer, less than 2 centimeters, with a consolidation to tumor ratio of greater than 50%. First registration was followed by intraoperative confirmation of eligibility. This excluded patients at frozen section who had benign disease, of course, or who had frozen section positive lymph nodes in the N1 stations. Those that proceeded, and there was 400 excluded because of these findings, were divided equally between lobectomy or segmentectomy. The primary endpoint was overall survival, but secondary endpoints included respiratory function and relapse-free survival, and of course, the detection of local recurrence. The typical Japanese patient in the study was a 67-year-old male, performance status 0, who actually was more likely to be a non-smoker, with good respiratory function with an FEV1 of more than 2 liters. On clinical radiology, the tumor was on average 1.6 centimeters in diameter, with a consolidation to tumor ratio of 1. It was almost invariably an adenocarcinoma, and 80% on pathology were T1A tumor, less than 2 centimeters. So the results were interesting. The difference in lung function was only found to be 3.5% in favor of segmentectomy, which, although it was significant, was probably not clinically relevant, and was certainly less than the 10% improvement that was expected by the power of the study. The recurrence pattern showed more occurrence in the segmentectomy group. There was a significantly higher percentage of local regional recurrence, and although less distant recurrence, the combined local regional distant recurrence was higher after segmentectomy than lobectomy, inferring that lobectomy, of course, is a better cancer operation. However, despite the higher recurrence, there was no difference in relapse-free survival. You can see there that at 5 years, nearly 88% in both groups were free of relapse. It was explained by Hisao Asamura that patients who developed recurrence were treated with adjuvant therapy, including radiotherapy, ablation, and of course salvage surgery in the form of lobectomy. The key finding was that the overall survival favored segmentectomy, and the survival curves started to separate at 4 years, such that the 5-year overall survival, although it was 91% in lobectomy group, of course these are very early cancers, it was significantly higher in the segmentectomy group. But looking at the cause of death, the survival difference did not appear to be due to cancer, but possibly due to cardiopulmonary disease, since the non-malignant disease as a cause of death was significantly higher in the lobectomy group. Interestingly, other cancers, including second lung cancer, was more common in the lobectomy group. So we'll consider the implications of that trial while we're thinking about it. But I also want to query why patients with N1 disease were excluded, since a big study of the National Cancer Database suggested that there was no significant difference in survival between those patients who had segmentectomy or lobectomy who had N1 disease. And certainly it doesn't seem logical to me to sacrifice extra lung parenchyma for systemic spread into lymphatics. Similarly, there is an argument why we should consider segmentectomy and not wedge. And there are 2 reports from the large American databases showing that segmentectomy has a significant overall improvement in survival compared with wedge resection. Segmentectomy, I think, is a reason to develop robotic surgery, and those of you wishing to put business cases in to have a robot in your unit can use the argument that segmentectomy is a lot easier to do by robotic surgery than it is by VATS. It is possible by VATS, of course, as Dominic Rousseau has eloquently demonstrated, but as a practicing thoracic surgeon for the last 30 years, I can tell you that it's the transition from that segmentectomy to robotic segmentectomy has saved a lot of worry and is a much more easy operation to accomplish. It allows for bimanual dissection of the individual segmental structures using the endo wrist, and you can include the distal margins of bronchus and artery very carefully, and it is important that this is done. Otherwise, what you're doing is in fact a glorified wedge. You must dissect and divide the individual hyoid structures. This slide demonstrates the benefits of near-infrared thoracoscopy and the use of indocyanine and green marker. The non-targeted diffusion segments after division of the artery appear fluorescent green, while the target lobe without the blood supply is not illuminated, allowing clear identification of intersegmental planes. And of course, the segmentectomy must be followed by the systemic nodal dissection. If we're going to do segmentectomy, we need to carefully understand the anatomy of the organ, and we need to go back to our medical school days and our anatomy books and learn the numbers of these segments. There are 10 segments in the right lung and 9 in the left, because one is fused because the heart is in the 8 and 7 segment. At Barts, we've gone on to apply the benefits of segmentectomy to an earlier use of it in terms of managing screen detected nodules, and the use of segmentectomy as a diagnostic and therapeutic tool. Small nodules not easily located intraoperatively, but deemed suspicious enough by an experienced multidisciplinary team, may have had PET, they may have had repeat scans in the screening programs. These were offered rat segmentectomy without a preoperative or intraoperative frozen section biopsy. These are some clinical examples of this patient with an early minimally invasive adenocarcinoma in segments 1 and 2 of the left upper lobe, preserving a well-perfused and non-emphysematous segment 3, a patient with a part solid nodule in the right 7 and 8 division of the lower lobe, which proved to be a T1C adenocarcinoma, and a complex peripheral adenocarcinoma, which could have been wedged, but was treated with a posterior basal segmentectomy of segment 10, a unisegmentectomy. These are as a breakdown of my personal experience of robotic diagnostic segmentectomy, showing the different and widespread use of the technique across the lungs on both fields. You can see the most common is the S1-2 of the left upper lobe, and there are typical segments of the superior segments of the lower lobes, of course, and the lingula, but there were 5 complex unisegmental resections and 35 complex bisegments, showing the wide versatility of this technique. It sped up the pathway. Diagnostic and therapeutic interventions occurred about only 3 weeks after the initial consultation. Hospital stay was on average 6 days, but some patients went home after 2. You can see the pathological nodule size was similar to the JCOG study. 74%, so 3 out of 4 of our patients had cancer. Of the benign cases, 7 had treatable tuberculosis. Conversion was 16% in the start of the experience, but there's been no conversion to either lobectomy or thoracotomy now in the last 40 cases. No patients have required intensive care, and there's been no in-hospital mortality. Now, conventional wisdom will favour a watch and wait over the potential morbidity of surgical intervention, and this is still the language used in some of the British Thoracic Society guidelines on management of nodules. However, robotic segmentectomy is not thoracotomy and offers a minimally invasive technique with maximal parenchymal sparing and minimal morbidity, and we view it as a therapeutic biopsy. As lung cancer screening identifies more and more early lung cancer, and as it becomes more difficult to obtain a preoperative diagnosis in these lesions, there may be a temptation to delay intervention pending growth of the lesion such that it then becomes more easy to biopsy. But of course, this delay will negate any benefit of early diagnosis. But we must be aware that the 8th edition of the TNM staging shows that there is a 5% reduction in 5-year survival for every centimetre of growth of that tumour, through PT1A to PT1B to PT1C. Feel free to quote these figures back to your MDT when they want to watch and wait a suspected cancer. The current MDT discussions may be like this: it's too small to palpate the lesion, it's too small or too far away to biopsy. Why don't we just let it grow until it becomes easier to find? We could put the patient to sleep and mark the nodule with a navigational bronchoscopy. We might be able to then perform a wedge resection around the marker. We could send it for frozen section. And if it's too small, we can always wait for the H&E to come back and then do a completion lobectomy. That is, I'm sure, what a lot of MDTs say on these screen detected nodules. I hope that where we find them in the future now, we'll find the chance of it being malignant to be high because it's grown and it may be PET avid. We can't get a tissue without a general anaesthetic. If we use a general anaesthetic, we may as well resect it using these techniques. We don't want to do a lobectomy. We can't get it in a wedge because we can't see it clearly, but we can see which segment it's in by knowledge of the anatomy. And we can get adequate margins with a segmental resection. So in summary, the JCOG 0802 has, I hope, changed many people's opinion, or at least justified what a lot of surgeons are already doing. With improved survival despite greater local regional recurrence, the segmentectomy over lobectomy for tumours of less than 2 centimetres should justify a change in practice. We await the further supportive, I hope, results for the CalGB trial that should be published or reported later this year. We should conserve functioning parenchyma to prevent the long-term complications, particularly of pulmonary hypertension, from restricting the pulmonary vascular bed. But we should achieve a parenchymal margin at least as large as the tumour itself. And we should include the bronchovascular resection lines in the specimen, it's not a wedge, and of course, a complete systematic nodal dissection. So these are the take-home messages: that all wounds will heal, but lung tissue will never grow back. We must balance the oncological outcome with lung preservation. But in the knowledge of the segmentectomy trial now that we have justified oncological principles to perform a less than lobectomy, but we do need to learn the anatomy of the organ in order to perform these operations satisfactorily. I hope this presentation, although ad hoc, will stimulate discussion, and I hope you'll go back to your units and discuss the implications of this fantastic JCOG 0802 trial. Many thanks for your attention.
Thank you very much, and a warm welcome. It's my honor and pleasure to welcome Mr. David Waller. Hi, David. While we wait for the chat box to fill up, because I can certainly see that the participant list has grown at the end of this talk. A very, very interesting game changer, do you think? And I think you've summarized it in your presentation, but would you be able to just give us some idea about the margins, the size of the lesion and the margins with regards to the JCOG trial, please?
So I hope you can hear me. The paper hasn't come out yet, and there was no discussion from Hisao in the AHES about the margins. All I can tell you is, as a rule of thumb, and from one American study about 10 years ago, 15 years ago, the margin should be as great as the diameter of the tumour. So that would be about at most a 2 centimetre margin. So most segmentectomies will cope with that. But I think the point is not how much we can take out, but how much we can leave behind safely. So you can see I rarely do a unisegmentectomy, maybe segment 6, but it's more common to do a bisegmentectomy, and that's to ensure we get a margin. There's no point doing R1 resections and very little point doing R2 resections. So I think I'm not advocating complex unisegmentectomies. There is a role for that, but I'm asking you to consider sparing more. Don't feel you have to take the whole lobe out. Leave the patient with as much lung as you can safely leave.
And I'm a great believer in that. Completely agree. The questions are flooding in, I have to say, and certainly one of the ones that stick out and which has been my point in some of the discussions is from Mike Shackles. Do you think N1 node frozen section is mandatory if you're performing a segmentectomy in a patient fit enough to tolerate a lobectomy?
So, Mike, where's the logic in taking out more lung parenchyma for a tumor that has already got systemic spread? So you're bolting the stable door and the horse is down the yard. For that logic, you would do a pneumonectomy for any occult N2 disease. So there is no logic in taking out more parenchyma when in fact what the patient needs is systemic treatment. May not be chemotherapy now, but once it's in the lymph nodes, it's in the body. It's a systemic spread. So I don't believe that we should sacrifice more lung parenchyma for somebody that's going to need chemotherapy. In fact, more likely to tolerate adjuvant therapy the more lung they have.
Another question coming in is, I guess the ones related to JCOG studies will have to wait for the actual paper coming in. Chris Sutter is asking, David, as you have indicated, conservation of lung tissue will improve survival. It will also allow treatment of additional tumors by sequential segmentectomy. It will be very useful in those patients with limited lung function to get survive benefit, i.e. patients not PS0. I guess it kind of relates down a different channel. We already know that limited lung function, we will give them an anatomical segmentectomy. This is talking about patients who can tolerate a lobectomy. So the conversation topic is related more to the JCOG trial and the future of what do we do with a small lesion. What if it's central? So you do a bisegment and you find a node that is positive later. Do we have the data to say N1 nodal disease with segmentectomy does as well as N1 nodal disease with lobectomy with no skip lesions?
Yeah. No, I showed you albeit a retrospective review. I think it was the SEER database where they found no difference in survival in N1. It wasn't dependent on how much lung tissue they'd lost. As I say, there's no logic in taking more lung because it's a systemic spread. But Chris is quite right, and that we will be dealing now with a disease that's changing and will be multifocal. Once you've taken that lower lobe out, it's going to be very difficult to treat a contralateral second primary because you're trying to keep the patient alive on one lobe. So that's why another reason to conserve the lung, particularly in sort of females in their 50s or early 60s, is they're going to come back with another cancer on the other side or an ipsilateral cancer. So you're just keeping your options open.
Yeah, thanks, David. I have a comment. I mean, it would be great if we had a lot of robots and a lot of theater capacity. But do you think that increasing our numbers will clash with the difficulties we have in capacity nowadays? We will be able to accommodate even with a broader definition of what we want to operate. We'll be able to accommodate that in theaters. We'll need to change radically the situation in thoracic surgery across the UK to be able to do that.
Francesco, I have absolute faith in the technical ability of the younger generation of thoracic surgeons, particularly yourself. I'm sure you'll be doing uniportal subxiphoid segmentectomies by VATS. I know some very talented surgeons in the north of England that are already doing uniportal unisegmentectomies. You guys are very talented at video-assisted surgery. You will be doing this by VATS. It's for older people like me to do it on robots because it's easier. But I'm sure it's quite within the capability of the younger generation of talented minimally invasive surgeons to be doing unisegmentectomies uniportally. You might struggle doing a subxiphoid basal segmentectomy, but you certainly could do a uniportal subxiphoid lingulectomy, possibly a posterior segmentectomy. The world's your oyster. You've got free reign to do it now. You don't have to take the lobe. You haven't got this 25-year-old study hanging over you. People in your unit saying, "Oh well, you know, the lung cancer study group said you need to do a lobectomy." You don't now. You've got free reign to go and do segmentectomies by VATS. The more you do, the better you'll get at them. You don't need a robot. It's easier with the robot. That's all.
An interesting question about the improvement or the relative preservation of lung function and a lack of preservation in the segmentectomy group in the trial. Any comments on that? Because we all noticed that.
So the lung's a big blood vessel. It doesn't matter about the alveoli. It matters more about the pulmonary capillary bed. You take it. We know what happens if you take away the pulmonary capillary bed. You put extra strain on the right ventricle. These patients, as they age, their pulmonary pressures go up because of their COPD. Most of them have got COPD. And that's probably what's killing them in the long run, is their right heart, because we're taking away pulmonary vascular bed. And of course, FEV1 is a very crude measure. It depends on a lot of other things, reversibility, small airways disease, stuff like that. But that effect on the right heart is what concerns me. That's why I do sleeves and not pneumonectomy. And a similar principle, why I don't want to take a lower lobe out in somebody with COPD, because that pulmonary vascular resistance will go up and their right heart will fail eventually.
So I think this is really, as you say, a game changer in terms of the newer generation looking at doing pulmonary preserving surgery with equivalent anatomical or pathological results, and obviously a systematic nodal dissection with it. And I think that's the message to go out, and I think you summarized it very well in terms of how you achieve it. If you do it through VATS, uniportal, biportal, triportal, or robot multiportal, or wait for the uniportal robot. But the aim is to preserve parenchyma so that the patient at the other end lives to die another day.
Absolutely.
Lovely. There are questions flooding in, and I think we will probably have to draw a line in terms of time, because I'm conscious we are over time. So many thanks for your presentation and for your participation, and thanks to my co-chairs, Francesco and Helen. And please look up on the chat box that the questions that we haven't been able to answer, we'll be archiving them and you'll find answers to them. And also please remember to leave the ratings on the presentations. Thank you very much. This is I think we're going on to the closing section now. David, thank you. Helen, Francesca, see you later.
Thank you.
Thank you.
Bye.
Bye.